I'm Zayna Khayat. I'm the future strategist at SE Health, St. Elizabeth Healthcare. So what does that mean? It's a fancy word for Chief Innovation Officer. I don't like the word innovation. I think we overuse it in healthcare in Canada, and so I really wanted to separate what my team does, which is we're about, I guess, protecting the future from the past or creating the future, which is next practices and next business models, next care models, instead of just trying to optimize the current. Both health as a word and an experience, and then healthcare, which is the services that help achieve health, are going to go through some pretty fundamental change. And you know, everybody's been saying this, but we really think it's going to happen. I think it's a combination of people have woken up, people and their families, particularly, I think this year baby boomers turn 75. They will not accept what we've offered for aging, you know, the way their parents did, and I think one was born every 10 seconds. So that alone is going to drive a whole new market we have never seen before. They've got all the information, and they've come to experience a certain level of convenience and value in every other service in their life, and then they get to healthcare and they're in a time warp, and those two worlds are just going to clash. The other is we're out of money, and so scarcity is a really good time to rebase and innovate, instead of what we do now is we just keep adding more and more money doing the same thing the wrong way and wondering why, you know, everybody's getting sicker, fatter, you know, et cetera. And then the third is there's technology now that didn't exist that's pretty cheap and scales really fast. So things are going to move, what we call it, an exponential curve instead of a linear curve. So put all that together, this kind of conditions for really a rebirth have never existed in 250 years of healthcare and medicine. And so what we see as the future of health is really these 6 big shifts, kind of at a high level, from reactive to not only proactive and preventative, but now predictive. So imagine running a healthcare system where you organize all your services around predicting what might go wrong and intervening then, instead of reacting when things go wrong. The second big shift is from extremely kind of crude and analog and imprecise, really, science. It's, you know, we think there's a lot of science, but there's not. We're pretty crude. To highly personalized, intelligent, and precise. So that's going to go from, we talk about healthcare going from a segment of one. So right now we treat everybody as one segment, one population, and everybody gets the average, which means nobody's needs get met, to an N of one. That's unheard of in medicine. The third big shift is kind of the location of where services will be experienced, from really an institution model, so buildings and clinics, and that won't go away, but you know, we won't have a mono channel. Much like if you're shopping, you don't only have one choice, which is to drive to a mall, shop, you know, park, and it's omnichannel. And so all that choice of channels will open up, not just for getting services, but for communication, texting, chatting, voice, you name it. And that's just going to explode. And that's where I think most of the new players will come in, not the incumbents. They're just not ready. They're stuck in their channels. The fourth big shift is from kind of episodic and intermittent care. So, you know, because we have to timeshare these really expensive resources of humans who are highly trained, and physical capital, bricks and mortar and equipment, we have to timeshare it. So you kind of come in, you have a 15-minute, you know, visit with, you know, with that asset, or drugs are just for this, or medical devices are just for the diagnostic and nothing else. Those days are gone. So it'll move to being highly continuous, integrated, and very team-based. The fifth shift, I'm almost done, is probably the one that excites me the most, which is a massive power shift in terms of decision-making power, in terms of who has agency and where trust is held. And you know, today we've outsourced that as users of the health system to the people who are the most trained. So providers have had all the power. That will shift to what I call people-powered healthcare. At a minimum, will be an equal partnership in terms of calling the shots, and soon patients will control everything for the fair share of situations, and the rest of us will be in service to them. My former boss used to talk about, you know, we're approaching an era where if you're a healthcare provider, you're going to ask the patient to subscribe to their data. because it's going to be way richer than your little bit of clinical data you happen to gather. So massive power shift, much like we've taken over a lot of power and agency in pretty much every other sector. And then finally, the last big shift, and I would say this is Canada's unfinished business, is a business model shift, which basically means what do we measure, what's the goal, what's the metric? And that's all shifting from being obsessed with treating healthcare like a cost center, paying for inputs and costs and beds and pills and visits and bodies, to, the only players left in the game will be being reimbursed based on the result or the value or the outcome. And that's where I think it's going to separate kind of the innovators from the non-innovators, and the non-innovators I don't think will be around much longer. If you look at the numbers, I think the latest published in Ontario was like 30,000 spots need to be created. I fundamentally challenge all those numbers. I think if we take every projection of everybody from their own industry who declares where the gap is, we need like all these more doctors, we need more home care workers, we need more long-term care beds. Every hospital is building more beds. Everybody claims they need another hospital. We need more drugs because we need national pharma care now. More. Hell no, that's not what we need. So, and then, I look at countries like Denmark that made choices, I think, in the 80s to never, ever build any more, like what we would call long-term care, like nursing home beds. And they're not crying in the streets that they need 30,000 more beds. So I think, first of all, I would, say, like, don't keep playing that card, because I don't think it's particularly helpful. And when you have scarcity is when you innovate. So then you start to look at, okay, what are some alternatives that help get you what you get out of a long-term care facility that might not need millions and millions of dollars of capital and, oh, by the way, decades to build. Assuming there's land and capital, and there isn't. Then you get creative. And so then I look at, okay, well, what do you do with the existing assets? And that's where we're seeing a proliferation of innovation around the experience in a facility like this, around finding alternative places for people to be, around palliative care at home, that we don't need to institutionalize in all cases, but then when we do, that we innovate on everything around the experience here, including, some of the shifts I talk about, a lot more intelligence about what's going on, in people's lives, in their bodies, in their environment. We see, new solutions in this space every minute of every day, because we also work in quite a few long-term care buildings. And we just find it very slow to get taken up. And I don't buy the argument, oh no, we can't integrate, I don't know, like a monitor for if people are falling or whatever, because there's nobody to pay for it. I'm like, no, that's not how innovation works. Innovation works because you would integrate that into your pricing, because you're going to get value on the back end, right? And I think that's the mindset you got to have. So I would encourage your staff here who are, seeing patients every day, is, find some opportunities and try to test some new stuff out, try new things. And I tell you, the one other customer we have that very few have been designing for is the family caregiver. That's a whole new player in healthcare that is going to get an entire new set of products and services surrounding them. We think there'll now be budget to pay them salaries. So what have you innovated around the family caregiver, which will indirectly affect the health of the patient, right? There's just so much opportunity. But again, you need a methodology, a system, permission, I guess, and a bit of courage to try some new stuff. I talk a lot about what we call these new entrants to healthcare. So these companies who never touched healthcare before, and now they're like right in it. So Best Buy, for example, is going full on into the home health business and home health care, and really outfitting your whole house to allow you to live independently as long as possible. Well, a new company got into that space over the weekend called Black & Decker. So you probably picturing the logo. I had to remember it because I'm not a very handy person. But they do tools like drills, and this is a tool company. Nope, they just partnered with a little startup called Pillow. And Pillow has kind of like a mini robot for the home. It's your little assistant, but it's really adorable and small on desktop. And it chats with you all day. It checks for seniors on their meds. It checks how they're doing. It's this companion, this digital companion, but it has what we call a botsonality. You know, it's not just like you're not talking to a phone. It's cute. And so Pillow has created a dedicated version just for Black & Decker. It's called Priya. She's adorable. And that's their product to get into the home health business, you know. And, you know, when these companies do this, you know, they've got scale, right? You can get to millions of people really fast. You know, instead of what I see a lot here in Ontario, which is like some academic designs something like Priya, and they're obsessed with it. And I'm like, dude, like, you're never going to scale this. You're never going to get the manufacturing right, the quality. And so, no, I'm not interested, you know. So anyway, I just think these kind of nouveau partnerships, and that would be another thing I would be encouraging Kensington to think about is, you know, how do you find some unusual suspects to do some pretty interesting stuff with? So there's some people are working on the policy side of creating basically a stipend for family caregivers, because you can quantify the ripple effects on the economy of people. You know, a lot are working adults who leave the workforce, so that alone decimates the economy, and it's just going to get worse. So in France, for example, they're paid. You know, so we're starting to see policy innovations, of course, always in other countries, and then we can learn from that, just like we did with cannabis, and then work out the bugs and work them here. Another example that, you know, we've been excited about is in Australia. They actually moved, again, what they call long-term care, which is seniors care, into, particularly in the community, into based on kind of an assessment, like a RIE type assessment. Everyone is stratified into 1 of 5 budgets or packages of need. So the lowest package is like $4,000 a year. The highest is like $15,000. And you get that budget as a family. You spend it on whatever the hell you want. If you want to get, you know, grandpa's toes done 4 days a week, get the toes done. If you need lawn services, if you need PSW, if you need nursing, if you need somebody to install an elevator, whatever. So a lot more decentralizing the choice and creating a bit more of a market instead of, you know, some central agency deciding everything and not actually being close to the client. So innovations like that are getting interesting. Another proposal I heard, just to kind of get in that theme of policy innovation that moves money around, is, you know, if we're going to wait for 30,000 long-term care beds and they're never going to get built, and we know it costs, I don't know, you know better than me, $150,000 a year or something like that from the taxpayer to finance the operations. Forget the capital, just the operations. Give that budget and put it in the home. Create 30,000 long-term care beds in homes. You know, we call this the homespital. It's totally being done all over the world. So there's lots of neat ways, you know, but again, if you in healthcare wake up every day and you're just obsessed with getting your thing done for today and not, you know, coming up and going, wait a sec, why am I doing it this way? What if we did this? What if we did that? You know, then, you know, we're just going to perpetuate and just keep asking for more money to do this, you know. So that's the kind of thinking we try to encourage in you know, people who think like we do in this space.